doesn't it?
Yeah.
Which brings us to the new health care law.
Yeah.
The Affordable Health Care Act. Some people call it Obama. I don't really care what you call it. It's there.
Yeah.
And the Supreme Court stamped it. It's probably going to stick around. How does that law impact the discussion of the value of innovation? I know people talk about this because it's mostly associated with value of therapy, the value of patient care. But we've got a whole research establishment that we've got to keep going too. Innovation is the key to this, right?
Yeah, I think what has to happen is there has to be some clear linkages to who's getting therapy and who's paying for therapy and who's paying for research, whether it's real pure research in the prospective manner or whether it's research in the gathering of post-market release data, you know, phase 4 research.
But is there something in the law that specifically addresses innovation in research?
Well, on the clinical delivery of care model, there are a lot of pilots. CMMI is putting out a significant number of model pilots and funding them with billions of dollars, and I think that's really for the good of the country, because what we're really trying to do is, as you are saying, save money. Where do we make the care that Richard delivers that's clearly high impact, how do we make that affordable? Well, instead of maybe discussing the specifics of drugs that cost $10,000 per therapy, maybe we should step back, take an overall system look and say, what is going on in our system and can we reduce waste? There have been studies that have shown that of all spending in the economy in healthcare, 30% of healthcare spending is wasteful. It's waste, abuse, misuse, whatever. So instead of making people take these life or death choices, maybe in the meantime, to buy us a little time, let's kind of squeeze the waste out of the system. And I think that's the approach that CMMI is trying to foster through these innovative demos, which I totally support.
I mean, it should be pointed out, 30% is a lot of squeezing.
It's a lot of squeezing.
That's billions and billions of dollars.
Now let's just reconcile that to the cost of drugs. Today, the cost of drugs in the healthcare economy is 10 to 11%. So if you reduced even half of the waste in the overall system, you would pay for all the drugs delivered today. That's a lot of money.
Even in Washington.
Yes.
That's a lot of money.
But it's harder to get than you think.
I'll bet it is, because one man's waste is another man's political pork barrel.
Exactly,
right?
Yes, yes.
Now, we've been talking about patient engagement here, because when you talk about politics, and that's what we've really been discussing in terms of waste in the healthcare economy.
Yeah.
You talk about politics, you're talking about elections, you're talking about the patient involvement, really, because there's us, doctors, and then there's the electorate, some of whom are doctors, but most are not, and they're going to vote, and they're going to be involved and engaged. So the patient engagement in the discussion of innovation, where does that fit?
That's a good question, and I don't know if I have a good answer for that one.
Don't worry about the cameras, the lights, nobody's listening.
No, right. You know, I mean, I think it's hard when you when you say the word patient, and I think it's really hard to talk about policy, because when you say patient, I think you talk about an individual.
Okay.
And for me, you know, who's used to talking to individuals and not about policies, it's hard to look at you and say, hey, this is what we want to do, this is the most innovative thing, but yet here's the policies that are going to, so I don't have a better answer than that, I'm sorry.
What do individuals do when they're faced with this question? I mean, doctors have the same issue, right? Every doctor is charged with doing the best for his or her patient. And yet a doctor is also charged with working the system so the system works for everybody. And sometimes they conflict. Does a patient have input in this?
It depends, because as I said, we have a heterogeneous delivery system and a heterogeneous payment system. And I would say that none of them have hit on the right formula for a harmonization of the clinical goals and the economic goals.
Maybe because it's really, really hard.
Oh, totally. And you know, I cited health technology assessment in Europe, and some might think that I'm a big fan of everything that goes on there, and of some things I am, in terms of data collection and data usage and some governance issues. But you know, they're having a lot of problems over there.
You think?
Yeah, so listen, this is not just a US problem, this is a civilized world problem.
Well, I remember not so long ago that I was told by policy people, by senators, congressmen, administrators, bundled payments. That's the way to go. Basically, we're going to shift all of this to you guys. Here's a bundle. You spend it the way you want. See you later.
Right.
Does that work? And what does that do to innovation, by
Right.
the way?
I mean, I agree with the principle of, giving some skin in the game to the physician to be the most efficient that he can. And I fortunately, practice at a place where I'm not really rewarded for extra, services or anything like that. So I like to think that I do practice in the most efficient way that I can, but I know that's not how everyone would practice. And even if they're not consciously doing it, maybe subconsciously or adding more tests and things, and maybe, some of the, protecting themselves from lawsuits and things like that. So
let's not even go there.
Right. So bundled payments, I think in general, I like the idea overall, but I do think it has some problems. I'm not sure how to make it better.
You could cap the system where it is right now, right? Just cap it, and then you would get no research. And what we've got now is what we've got going forward. Nobody wants that, do they?
No, I think what Richard's really describing is that the problem is in the execution of bundles and the governance of bundles and the financial responsibilities that then ultimately flow from that. One thing I learned when I left clinical practice and I went into the payer environment is that actuarials know a lot. And what they know is that if you can predict how much it costs to take care of a population, you really need to have that money on hand. Because if you don't, you're in a world of hurt.
Governments can print money, but that's not necessarily a good idea.
Yeah, so the way that relates to the bundle payment argument is that if you shift the risk onto a provider or delivery organization, and we're doing this with accountable care organizations, those entities need to have as close to perfect knowledge as possible, not only what the clinical condition is of their population, so the risk adjustment, but what the costs of that risk adjusted population will be so that they can have the money to do it. Richard's part of Mayo Clinic, they're big, but they may not be big enough to handle those super expensive patients who get PD-1 inhibitors, and they may need reinsurance to cover them for high costs. They may need to reserve an amount of capital that's beyond their business mission, maybe $100 million, maybe $1 billion. So that's where I get into this clinical and financial harmonization that's not here.
So those guys in the back room.